Let's jump right into the diagnostic logic for Step 2 CK Neurology, focusing heavily on spinal cord and nerve root pathologies.
Here is what we're covering. Back pain diagnostic logic, spinal cord compression, traumatic cord syndromes, cauda equina versus conus medullaris, ALS and upper motor neuron clues, and finally, dysreflexia and optic neuritis.
Section 1. Back pain diagnostic logic. When you get a question presenting back pain plus a neurologic deficit, you need to sort it fast. First, separate trauma from cancer or infection. Then, localize it. Is the pain in the neck or down in the thoracic or lumbar regions? Next, you've got to differentiate upper motor neuron from lower motor neuron signs. Check if the weakness is symmetric or asymmetric, and always evaluate for bowel and bladder dysfunction. Pattern recognition here is key.
Evaluating specific clinical clues really helps isolate the pathology. If the pain is constant, gets worse at night, or doesn't care how the patient is positioned, you should lean towards spinal metastasis. On the flip side, if there's focal tenderness with a fever, a recent infection, or IV drug use, pivot your focus to vertebral osteomyelitis. Degenerative joint disease, that's positional, usually getting better when the patient just rests.
Section 2. Spinal cord compression. The chronology of physical exam findings is everything here. Causes can range from mechanical disc disease and spinal stenosis to epidural abscesses or malignancies like lung, breast, or prostate cancer. These patients show up with gradually worsening severe back pain that hurts more when they lie down or at night. Early on, you'll see symmetric extremity weakness and decreased deep tendon reflexes. But as the compression gets worse, the late signs kick in. Decreased rectal tone, hyperreflexia, a bilateral Babinski reflex, and eventually paralysis.
For next steps, getting an emergency spine MRI is your top priority to confirm the diagnosis. You also need to call in an urgent surgical or radiation oncology consult. Now, if you suspect malignancy, you've got to give intravenous glucocorticoids immediately, often before you even get the MRI, to bring down the edema and save their function. But if you suspect an infection instead, skip the steroids and go straight to broad-spectrum antibiotic.
Take a look at this epidural abscess compressing the cord. When you see the classic triad of fever, severe focal back pain, and neurologic findings like motor or sensory changes, an emergency MRI is required. And remember, doing a lumbar puncture is completely contraindicated here. You do not want to risk inoculating the cerebrospinal fluid and spreading that infection further.
Section 3. Traumatic cord syndromes.
Let's look at central cord syndrome, which usually happens after forced cervical hyperextension injuries in older patients with some existing degenerative changes. Because the upper extremity corticospinal tract motor fibers sit closer to the center of the spinal cord than the lower extremity fibers, you get disproportionate upper extremity weakness. Basically, their arms are way weaker than their legs. They also often complain of a burning pain in their arms and might have some localized pain and temperature deficits.
Now compare that to anterior cord syndrome. This one is driven by vertebral body burst fractures or an anterior spinal artery injury. The result? Complete bilateral motor paralysis and a total loss of pain and temperature sensation below the lesion. But here's the catch. The dorsal columns are in the back of the cord, so they're totally spared. That means vibration and position sense are remarkably preserved.
Section 4. Cauda equina versus conus medullaris.
Both of these are bad news and require an emergent MRI and surgical decompression within 24 to 48 hours to prevent permanent damage. But figuring out which is which depends on checking reflex symmetry and pain severity. You need to know if the lesion is up at the L1, L2 level, hitting the spinal cord tracts, or further down at the L2 sacrum level, hitting the lumbosacral roots.
Cauda equina is a lumbosacral root disease. It hits you with severe radicular pain, asymmetric motor weakness, asymmetric saddle anesthesia, and strictly lower motor neuron signs like areflexia or hyporeflexia, plus bowel and bladder dysfunction. Conus medullaris affects the distal cord. It causes severe low back pain, but the radicular pain is mild or not even there. The deficits are symmetric weakness, symmetric perianal numbness, and it features both upper and lower motor neuron signs.
Section 5. ALS and UMN clues.
Watch out for this classic clinical trap. Diabetic neuropathy is purely a lower motor neuron disease. So, if you spot upper motor neuron signs like a Babinski reflex, hyperreflexia, or spasticity in a diabetic patient, do not just pass it off as neuropathy. Things like a sensory level or new bladder symptoms mean you need to immediately shift your focus to a brain or spinal cord disease. Pronator drift is an incredible, highly specific physical exam finding that points straight to pyramidal tract or upper motor neuron disease. Have the patient extend their arms, palms up, and close their eyes. If one arm pronates and starts drifting down, you've got a definitive upper motor neuron clue localizing right to the central nervous system. Amyotrophic lateral sclerosis, or ALS, is unique because it blends upper motor neuron signs, like spasticity, hyperreflexia, the jaw jerk, and a positive Babinski, with lower motor neuron signs, like muscle atrophy and fasciculations. It happens because both upper motor neurons in the primary motor cortex and lower motor neurons, like anterior horn cells, are deteriorating at the same time.
Beyond just the limbs, ALS brings bulbar symptoms like dysarthria and dysphagia. Here's a high-yield test scenario: early respiratory insufficiency. It can actually mimic obstructive sleep apnea with orthopnea, daytime fatigue, and morning headaches. Diagnosis is mostly clinical, using EMG and an MRI to rule out mimics. For management, you're looking at riluzole, non-invasive positive pressure ventilation for respiratory support, and a PEG tube for nutrition.
Section 6. Dysreflexia and optic neuritis. If a patient has a spinal cord injury at or above the T6 level, a noxious stimulus below the lesion, something as simple as a distended bladder, can trigger a massive, unregulated sympathetic response. All that vasoconstriction causes severe hypertension. The body's baroreceptors catch this high blood pressure and fire off a compensatory parasympathetic response above the lesion, which drops the heart rate, causing bradycardia.
Telling these autonomic emergencies apart comes down to hemodynamics. Autonomic dysreflexia gives you massive hypertension and bradycardia from a trigger in lesions at or above T6. You manage it by removing the trigger and fixing the blood pressure. Neurogenic shock, though, happens with lesions above T1. It's a total loss of descending sympathetic tone, leaving the patient with severe hypotension, bradycardia, and hypothermia.
Let's wrap up with demyelinating diseases. For multiple sclerosis, remember it requires dissemination in time and space. An MRI is central here, and a lumbar puncture for oligoclonal bands helps when things are unclear. A classic presentation is optic neuritis, causing painful monocular vision loss, washed-out colors, and an afferent pupillary defect. Also watch for transverse myelitis, which causes bilateral weakness, a sensory level, and bowel or bladder dysfunction. If you see aquaporin 4 IgG, think neuromyelitis optica. Severe immunosuppression with the JC virus points to PML. CIDP progresses over 8 weeks and responds well to steroids, IVIG, or plasmapheresis. And finally, central pontine myelinalysis follows rapid sodium correction and can lead to delayed locked-in syndrome. Memorize these presentations and you'll nail this on the exam.